Good morning. I'm Dr. Meredith Warner of Warner Orthopedics and the Well Theory. And today I want to talk to you about a topic that's near and dear to my heart as an orthopedic surgeon and as a female, osteoporosis. Specifically, what is it? How do you prevent it? What makes you get it? How do you treat it? What can you do to be proactive to either prevent it, or if you have it, keep it from getting worse and potentially even improve it? Thanks for logging on. Tell your friends. I hope my mom is watching this because she literally just asked me a question about some medication. We'll talk about that at the end of this talk. Okay, this is my team right now. I have a practice in Baton Rouge, Louisiana. I actively see patients. I am not an AI-generated chatbot. I am a real person. And you can certainly always come to Louisiana and see me if you have concerns about your bone health. All right. That's good. Okay, so think of this, think of bone as like a bank account, like a skeletal bank account, okay? The only reason we have a skeleton, besides to hold us upright and resist the, acceleration of planet Earth and the force of gravity and all that, which is kind of like a side benefit of a skeleton. The real reason we have a skeleton made of calcium, magnesium, hydroxyapatite, those kind of substances, is the body needs a place to have a depot for calcium. Why? Calcium is one of the most integral minerals and ions in your body. It is necessary for all neural communication, all cellular communication, and the communication between your brain and your muscle. It's a cofactor of many enzymes. It's just ubiquitous and massively necessary. And your body wants to keep you in a very tight band or amount of calcium. We've talked about this before. There's very few things your body really, really cares about. When it does care about it, it keeps you in a very tight band. One is your pH balance, your acid-base balance. One is your electrolyte balance, your mineral balance, and then also temperature. Okay, massively important in the human body. Why? Because certain reactions can only happen in a band of temperature. If it's too hot or too cold, that chemical reaction can't occur. Most of those are the reactions that are necessary for us to be alive. So calcium is one of these substances. Your body has to have a method to find calcium when we don't find it from diet. Where does it do it? Puts it in bone. When you don't have enough calcium in your system, it's going to pull it out of your bone. Okay? So think of bone like your skeletal bank account for the rest of your life. Okay. Osteoporosis. So a lot of people don't really think about this because you don't feel it. It's almost like heart disease. Until you start getting short of breath and having chest pain, you really don't know that you have heart disease, right? The only way we know is you go get screened. You go get your blood work done. Sometimes you do a calcium cardiac score. Sometimes you do a stress test. Sometimes you do angiography, okay? There's different tests to try to find this before you get a heart attack. Well, the problem with osteoporosis is you don't feel it. You don't know about it until you get what some people call a bone attack. What is that? A fracture. So a lot of times, the first time we pick up osteoporosis is when you break a bone. The worst case scenario is when you have a hip fracture. And I'm going to talk about that later, but you definitely never want to get a hip fracture because the mortality rate is 50% within a year. Now, this is Australian data, and I'm going to tell you why Australia kind of plays into this later. There's a group out of Australia that has done a lot of work in methods to build bone back. But anyway, over 50, if you're age over 50, you're projected to have poor bone health, 31% of you. Okay, and we can project that to the Western world. So fully a third of us are going to have poor bone health over the age of 50. Some of that's going to be really bad bone health. Some of it's going to be kind of sort of bad bone health. And the other 60%, they may or may not have optimal or perfect bone health. They don't really ever tell us that in these studies. The number of fractures are projected to skyrocket over time because of osteopenia and osteoporosis, which of course leads to more healthcare costs, et cetera, and worse, death and morbidity, becoming dependent on other people, becoming fragile, having to ask for help everywhere you go because you had a hip fracture and your legs don't work anymore and you've lost all your muscle mass. And then if you have one fracture, your risk of getting another fracture propagates and increases. This is true in almost everything in medicine. If you've had one heart attack, your risk of another one's greater. If you've had back pain, your risk of having more back pain later is greater. Neck pain, same thing. Fractures, same thing. So the goal is to find out if you have bad bone early, take care of it, and not get an osteoporotic fracture. So again, it's a silent epidemic. It is happening, but we don't know it's happening. It's almost like what ultra-processed food has done to us, silent for decades. And now all of a sudden in our health outcomes on a population scale, we're seeing the manifestation. But it was super, super silent ever since Kellogg made that first cereal. Okay, and I gave a talk on that. You can watch on the advent and the beginning of ultra-processed foods. It's actually a fascinating story in the history of America. We think osteoporosis is going to affect about 200 people worldwide, 200 million people worldwide, not 200. Probably it's going to be more if there's going to be 9 billion people on the planet, and a third are going to be at risk of osteoporosis over the age of 50. So that's really 3 billion. I think this is the current estimations of people that actually have doctors that diagnose them. So that's kind of a false number. I think it's low. The estimate in that body of literature is 200 million. The prevalence of people over 50 in Australia with osteopenia or osteoporosis is 66%. Now that's in contradistinction to what we just said, that 30% are going to be at risk. The actual numbers are even worse. And then the fracture burden correlates to that. So the more people that have crappy bone, the more times you're going to have fractures, okay? And then the mortality rate. So if you're a man, you're over 60, and you get a fracture from osteoporosis, your risk of dying within 5 years is fully 3 in 4, 75%. For women, it's half, 50%. Why is it lower? I have no idea. The economic costs, we don't need to talk about that. Who cares? They'll just print more money, right? So it just skyrockets. We get more inflation, more healthcare inflation, et cetera, et cetera. But for your purposes, for your bank account, for your future wealth, and to live happily and optimally in your older age, you don't want to get a fracture. You don't want to count on the government to treat you. So your real goal is prevention. And then if you do get this disease, to prevent the fracture.
Deb says good morning.
Miss Deb says good morning. Thank you. Good morning. All right. Okay. So what is osteoporosis? So the word itself kind of makes sense. Osteo is bone. Porosis is porous. So porous bone, meaning bone with a whole bunch of holes in it. Think of it that way. It's like your bone got shot with a shotgun and there's a million holes in it, which weakens it and leaves empty spaces, and then thin, tiny little bridges of bone around those empty spaces that are prone to fracture. Technically, it's a skeletal disorder characterized by compromised bone strength, predisposing an individual to an increased risk of fracture. This is the only reason anybody cares about osteoporosis. Now, there's a whole body of literature growing about how bone health is linked to muscle health and linked to brain health, but that's kind of in its early stages, so we're not going to talk about that too much. The real reason population health, governments, doctors, hospital systems, insurance companies, and you care about osteoporosis is the fracture risk. You don't want to break a bone. It slows you down, it hurts, it requires money to treat, it takes you out of work, you have disability or impairments afterwards, et cetera, et cetera. So you don't want to get a fracture. How do we define it? We based it on the World Health Organization, which of course we don't belong to that right now, but we used to. The World Health Organization's T-score, okay? And I'll explain that very briefly. Everybody out there has probably seen the normal curve, a normal distribution, if you remember that from math class. Most things follow a normal distribution, height, weight, eye color, et cetera, blah, blah, blah. What that means is the middle, the 50% line, most people live there, but there are tails on either side. There are outliers. So there's some people that are taller, some people that are really short, but most people are in that, 5'8", 6'1" range, whatever. Same thing with bone health. They basically took a group of people, did bone density scores, and created a normal. The T-score is the 50% point, or the normal score, and it's arbitrarily given a designation of the number 50 on the scale. And then within a standard deviation, which is another statistical thing. So within the outlier population, we expect a certain group to fall here, a certain group to fall here, here, and here. So within the standard deviations of plus and minus, if you have a T-score of 50, you're considered normal, even up to -1, which arbitrarily is designated 10 points lower. But then if you get down below -1, -2, -3, you're defined as either osteopenic weak bone or incomplete bone, or osteoporotic, negative 2.5 on that scale. The T-score compares you and me to a group of normal 20 to 30-year-olds, okay? The Z-score compares you to other people in your age group. So if you have your DEXA scan in front of you, you can look at your T-score, you can look at your Z-score. If you compare yourself to a 30-year-old, you're probably not going to score as well. That's a bit disheartening, but you can always look at the Z-score and make yourself feel better. And then if you have osteoporosis, we're going to talk about how to tackle that. Again, here's the Australian number. 3/4 of people had terrible bone. 1 in 3 women, 1 in 5 men are at risk of fracture. And then an osteoporotic fracture occurs every 3 seconds worldwide. And of course, that only includes the group of people that are actually, near a hospital and can actually get a diagnosis. There are probably billions of people that have healthcare problems we don't even know about or think about because they have no doctors, they have no hospitals. I see this all the time. I treat patients in New Orleans at the Safety Net Hospital. I teach for LSU, go Tigers. And we treat a lot of immigrants. A lot of the immigrant population comes in. And I can't tell you how many people in their 50s and 60s have never seen a doctor their entire life. And you ask them pre-op, what's your health like? Oh, I have perfect health. Then you send them for a few blood tests. Lo and behold, massive things are uncovered. So that's probably underestimated numbers. So just know we're all at risk of bad bone health.
Kathy just wanted to add that she fractured her foot about 3.5 years ago and realized she had osteoporosis after that.
Miss Kathy just wrote in or texted in or whatever you call it, chatted in, and said she picked up her own osteoporosis from a foot fracture. I will tell you, if you have a fragility fracture and you're under the age of 65, I would push your doctor to get a DEXA scan. Remember, the insurance companies don't want to pay for it until you're 65, but there are certain risk factors or things that happen in life that can get you one earlier, and I would always push to get one earlier. So this graph is really just meant to show you your skeletal bank account. So you're born, you have time to build up the bank account, and most of that building is in the adolescent years, okay, like 12 to 18 or so. That is the time you can build bone. So if you have kids or grandkids, please make sure they're drinking enough milk. Please make sure they're drinking actually whole milk, organic if they can, taking calcium if they can't, eating foods that are high in calcium, getting their D3, getting out in the sun and exercising. That is their best chance to build their skeletal bank account to invest in their future skeletal health. Then you get peak balance, which is the top of this curve. We live there for a while. And then all of a sudden it starts to drop. The men have a slower decline. Women have a precipitous drop. Of course, why? We get the short end of the stick here again, menopause. So menopause happens, you lose your estrogen, you lose your progesterone, terrible things like hot flashes happen, but worse, your bone is no longer protective. Estrogen is protective of bone. You lose that protection, your body says, I don't want this bone, and starts to throw out the calcium. So menopause is a huge problem, and we should all probably go to our treating physicians and discuss hormone replacement therapy, if for no other reason than to protect your bone and your muscles. Hot flashes notwithstanding, although those are super duper annoying.
Kathy said she's 61.
Kathy's 61. Yeah, so she's in the sweet spot. So if you had a fragility fracture, yeah, you go get a bone density scan and get diagnosed, because then you can treat it. All right. The adolescent years, we just talked about that. Make or break period for building bone mass. Please get your kids on calcium if they don't drink a lot of whole milk all day long. 40 to 60% of your adult bone mass is accrued during this time, okay? This is when you're investing for the future. Think of it like your retirement account, okay? If you're not putting into your IRA of bone in your teenage years, you are not going to have a retirement. You're going to get fractures. You're going to be weak. You're going to have sarcopenia. You're going to be fragile. You're going to be sitting on the couch miserable, okay? So make sure, if it's too late for you and too late for me, make sure the people you know in this area where they can build the peak bone mass are investing for the future. Just like you tell your grandkids to buy stocks and not the latest Nintendo game, right? Tell your kids, you know what? Take calcium, drink milk, don't drink that soda. Here's what you'll look like when you're in the future if you drink milk, strong, healthy, happy. Here's what you're going to look like if you don't. Something like that. Really encourage this in your family members. Then you're going to hit that plateau. You still can, protect your bone in that plateau period. And then during the drop, you can protect your bone then. And we're going to discuss how. Now, if you have early menopause, that's a whole different conversation. And I have plenty of patients that either had a hysterectomy or some other reason that they went into early menopause. And I cannot tell you how many of them tell me they never had hormone replacement therapy, even if they lost their uterus and ovaries at the age of 30. It is mind-blowing, the terrible care of bones in this country. Next slide. Okay. So one thing, I threw this in here just as food for thought. People with anorexia, the people that don't eat, that worry about how skinny they are. I eat all of the starlets that seem to be taking Ozempic like crazy, that are in movies about witches and stuff that we've seen recently. People with anorexia are automatically not adding to their bone bank account, and in fact are probably taking from it, even at that early age. So this is one of those situations where probably this should be a little bit more advertised in the skinny world. You've heard me talk over and over again how bad being obese is for you, but the opposite is also bad for you. Once again, nature is Goldilocks. You don't want too little, you don't want too much. Nature loves a balance, wants to be in the middle. So make sure, if you know somebody that's not eating enough or is taking Ozempic for fun, you know, having their little Ozempic parties that people seem to have lately, that they understand the long-term implications of not providing enough mineral for the body. And that's probably enough about that. Hold on, we have a question.
You had someone who had a hysterectomy at 38 and no HRT.
Yeah, so one of our audience members said she had a hysterectomy at 38, no hormone replacement therapy. It is insane to me. Now, I will tell you that there was this time period after the World Health Initiative study where everybody gets scared to death of hormone replacement. Before that study, Premarin was the #1 prescription in this country. After that study, it plummeted because the bad interpretation of some data in that study made everybody think it's going to cause breast cancer. That has been disproven, I don't know how many times since, unless you have certain risk factors. But yet there's this whole generation of physicians and protocols and algorithms that have been built that say don't do it. So you really have to have somebody that understands this, understands the literature, and can think outside of the box to make sure you're being treated properly. All right, we already talked about that. We can go to the next one. All right, so if you have stalled bone accrual, like if you just decide, oh, I'm not going to invest for retirement, I'm just going to see what happens, maybe I'll win the lottery, that is probably not going to work out for you, although that does seem to be the plan for a lot of people. During adolescence, 40 to 60% of your peak bone mass is acquired. If you don't eat enough food, especially protein, by the way, if you don't eat enough minerals, especially calcium, magnesium, etc., then you're not going to have that peak bone. Remember the graph I showed you where it goes up, you plateau? Well, if you're only going to be down here and then you drop, then where are you? Well, then you're really at fracture risk later on. And when I say later on, I mean like 40 or 50. And also, if you don't start your period, if the onset of your period is before 18, that is associated with lower adult bone density. And I think this means after 18, that's a typo. So if you don't start your period until late, like say 17, 18, then you're not producing enough estrogen to build up your bone mass. So anybody out there may or may not have heard of what's called the female athlete triad. And this happens to a lot of girls. They exercise a ton, they don't eat enough, and they are amenorrheic, meaning they don't start their period. And these are the girls that are at risk of crappy bone later on. So if you know an athlete that runs a ton, doesn't seem to eat a lot, and maybe has some other signs like thinning hair, hair growth all over the body, fine downy fur, things like that, all that's indicative of poor caloric intake. Maybe help that person out and just suggest at least take some calcium, take some vitamins, just so we can help at least prevent the future fractures that are inevitable. And then there's other things, like if you have low IGF levels, if you're hypogonadism, like if you don't produce enough growth hormone growing up. So there's some genetic things that are going to predispose you to poor bone mass. All this is treatable if you pick it up early.
I don't know if you want to answer this now, but you can just tell her it may be coming. But Jessie Ann, she had an underlying blood clotting disorder, so she's not eligible for HRT. And her doctor won't prescribe it. Are there other options for her? I guess you're going to get to it.
Yeah, somebody out there said they have a blood clotting disorder, meaning they're prone to forming blood clots. So their doctor won't let them have estrogen, because estrogen, at certain doses for certain people does have a slightly increased risk of blood clot. So it's probably a legitimate contraindication. And the question is, what else can I do? And I'm going to talk about that. Okay, so here's some interesting information. I always find it fascinating to go look at the anthropologic literature and like any studies of people before modern medicine. You know, like what were the cavemen doing? What was their health like? I don't know why that fascinates me. So I found this tribe in lowland Bolivia, the Tsimane, and I'm sure I'm saying that wrong. So the title of the slide, which you probably can't see because I made it all too wordy, and I apologize. The reproductive trade-off, a surprising fracture risk in a high activity population. Okay, so here we have a bunch of hunter-gatherers. They're very active. They're very strong. They eat a whole diet. They're, you know, blue zony, if you will, but they have a very high rate of osteoporosis and fractures, specifically thoracic vertebral fractures. So this is the thing that most people don't want to end up like, the hunchback little old lady, because each vertebral body compresses and wedges and they get that kyphotic look. Apparently in this forager horticulture or hunter-gatherer group, this is very, very high rate. And it's nobody could figure it out until they went and looked at the total lifestyle of these people. So what the problem is here is they have very high birth rates. So you may or may not know this, but every pregnancy you have is yet another extraction from your bone bank. So you're growing a human being inside of you. What is your body going to do? It's going to extract what it needs to grow that human. One of those things is calcium. So there's a high rate of bone mineral density dropping in pregnancy, during pregnancy, after pregnancy. So if you're in a population that never stops being pregnant, you're really going to have diminished bone density and then have multiple fractures. So that's another risk factor that you have to think about. So the Tsimane population, highly physically active, yet their thoracic vertebral fracture prevalence is much higher than Americans. So here's one of these populations that we all look up to as being much healthier than us that has a huge problem with a huge issue. Vertebral fractures are no joke. They change your sagittal balance, meaning the balance of where your center of gravity is when you're upright. As you bend over, your balance changes. You can't look up and see obstacles, things like there's a whole host of issues you don't even think about. And then also it compresses the abdominal organs and makes it harder to eat, harder to breathe, et cetera, et cetera. Same thing that kind of like scoliosis does. And even though their diets are better in terms of protein, in terms of vegetables, et cetera, they're actually eating way better than us. They're more active than us. They should be way healthier than us. They have so many babies that their thoracic fracture rate is higher. So just remember, pregnancy is an extraction event. Yet another reason to take prenatal vitamins as though we needed more. And also to continue to treat your bone after pregnancy, especially if you're going to breastfeed, obviously. All right, so shorter mean intervals between the birth, et cetera, greater reproductive effort associated with this higher thoracic vertebral drop in bone mineral density. I think we beat that dead horse. All right, next slide. That's more of the same. Okay, so what happens? What do we worry about? We don't need to worry about that in particular. Some people do, but most people in America, we don't even keep up with our death rate at this point. Most families are having less than 2 kids. Loss of population is a big risk now. Remember how everybody was scared there's going to be overpopulation 10 years ago? I'm sure in 10 years that'll be the risk again. But we don't have to worry about a very high birth rate in general in this country. Our biggest worry is mostly menopause, which means mostly women we worry about, which is kind of a shame because I think the men are neglected here. I think a lot of times people fail to order these studies in men, and men could be treated. And you saw that the death rate is higher for men if they get a fracture. So that's probably yet another hidden epidemic is osteoporosis in men, because we don't have the studies because nobody thinks to do them. Nobody orders DEXA scans on guys in their 60s and 70s. And maybe we should be. That's another thought. So we have a hormonal shift at menopause. This is when we drop our bone. Estrogen declines, progesterone declines. There is a direct loss of bone mineral density, putting you at increased risk of sarcopenia, loss of muscle, osteoporosis, loss of bone, and also cardiovascular disease. We assume there's going to be a 10% loss of your bone mass during the decade after menopause, if not treated. So this estrogen decline definitely accelerates your bone loss. And here's a graph yet again showing it. So you see the graph goes up to the right between like 0 and 30, plateaus, and then 40 down, it drops. Now the average age of menopause in this country is 51. So anything before that is early menopause. Anything after that is going to be late menopause. What happens, the bone cells, osteoblasts, have receptors for estrogen. As they stop getting this input, they behave differently. And the coupling or the balanced behavior between osteoclasts, which are bone-eating cells, and osteoblasts, which are bone-forming cells, changes in favor of the osteoclasts. So that's what estrogen is doing for you. It's keeping the balance on the plus side, or at least in between. Once you lose that input, you start to go towards the negative side, and the osteoclasts win. So what can we do? Well, a lot of people ignore it and hope that it doesn't happen to them. Maybe it'll go away. I think a lot of doctors do this too. Some doctors and some of the literature previously, up until, let's say, the past 3-5 years, would have you avoid all activity if you were osteoporotic. So I've had patients tell me their doctor told them, don't lift weights because you might break your bone. Or no, you can't go run, you might break your bone, et cetera, et cetera. So that was the prescription before, which I can tell you is 100% not true, with rare exception, and actually makes the problem worse. You could take medication. A lot of people are scared of taking osteoporotic meds. I'm going to tell you why I don't need to be scared. And what's interesting to me nowadays is the same people that are scared to death of osteoporotic meds, which have been studied heavily and have a very low risk profile, also are willing to take totally unregulated injections from shady operators in the hopes of losing weight or feeling better. So there's this cognitive dissonance happening in the country right now. You can take osteoporotic meds. They're good meds. They help you. They prevent hip fracture. They can build bone back. There are side effects, just like with anything, but they're very, very low rate, like rare. And then there's another way you can fight back called lifting heavy things. So weightlifting, and I'm going to talk about that. And weightlifting is also preventative of osteoporosis. So the stronger you are, the heavier you can lift, the more likely you're going to have good bone. Okay, medications. I will tell you that osteoporotic drugs save lives. Remember I told you the fracture rate of a man over 60 with an osteoporotic fracture is 3 out of 4, 75%. The death rate within 1 year after a hip fracture is 50%. Okay, half of women after a hip fracture are going to die in that first year. That is really sad. So if you can prevent that hip fracture, you've basically saved a life, more or less. So my opinion, getting good bone health is life-saving. Hormone therapy helps, but as we've already learned from some of the people watching this with us, some people can't take it. It's contraindicated. So what do? I will tell you the best thing you can do is lifestyle and heavy lifting. So if you smoke, you have to stop smoking, highly associated with damage to bone cells. Okay. If all you eat are potato chips and French fries that are delivered to your house and you don't actually get off the couch to go get them, also not a good prescription for bone health. If you don't eat anything with calcium, not good. Okay. Your body has to have calcium. It's going to find it somewhere. And then resistance training, which I'll get into later, probably the best thing you can do for yourself for a variety of reasons. It improves your bone health, it improves your muscle health, it improves your balance. If you're well balanced and agile, you're also low risk of fracture. So if you have strength, good bone, and good balance, your risk of getting a fracture later in life is slim and none, which saves you a ton of time and money, not to mention pain and impairment. So those are your weapons against this, your methods to mitigate. Okay. Physical activity is the cornerstone of bone health, okay? Moderate intensity resistance training programs do not appear to induce sufficient strain to stimulate notable improvements in bone. That is very wordy. What does that mean? This is from the literature, big review studies where they looked at lifting as a prescription for bone health and poo-pooed it for a while. Well, what we found was if you don't lift enough, sure, it's not going to do anything. So if I sat here with a 2-pound curl bar and did this and told you that was going to help my bone health, you would probably think I was crazy, and you would be right. But a lot of the work before, they weren't lifting enough. It was very wimpy programs, okay? Everybody was scared of breaking the person. Everybody thought women couldn't lift weights, et cetera, et cetera. But now we do have a new protocol that was developed in Australia. Remember, I told you I'd bring that back to that. So we need more of this evidence-backed exercise protocols that are safe and powerful, potent enough to build bone in an at-risk population. So that's the Lift More protocol out of Australia. I'll probably talk about it a little bit later. I'm not going to get into like how you do the lifts and everything. It should be supervised because it's serious lifting. And a lot of women, particularly in their 50s and 60s and 70s, maybe weren't exposed to sports, okay? Maybe weren't encouraged to lift weights when they were kids like the guys were. But you need to be doing like military presses, deadlifts, squats, and jumping up and landing and impacting because the bone responds to impact. And I'll tell you what you need to do, but I would say go see a physical therapist or a doctor like me who knows about this protocol, who knows about weightlifting, and can help you and guide you. First of all, you'll feel a lot better because you're going to be stronger and you'll be able to pick up your grandkids with no problem. Second of all, you'll be helping your bone a ton, as much or more as the medications in some cases. But when you combine it with the medications, you are having a double whammy and you can actually bring back your bone density like 6 to 10%. So those are the mitigating things you can do. If you can't do hormones, you can still do the medications, diet, lifestyle, and lifting. Okay, so this is high intensity resistance training, or HIRIT, or however you want to say it, based off of high intensity training, HIT protocols, right? You probably heard about like riding real fast on your Peloton or sprinting or jumping up and down or going up and down stairs to get your VO2 max and your cardiovascular fitness back. Well, you need the same thing for lifting. So if you do very high intensity lifting for short time periods, you can build strength and build bone mass. This does not take a lot of time. The Lift More protocol, I want to say, is 2 to 3 days a week for about 20 to 30 minutes. That's it. And you can build back bone density. It's pretty amazing. The bone, like every other tissue in your body, is able to change and grow. You were falsely told it couldn't. You can build bone back. You're not going to build all of it back probably, but you can build enough back to prevent fractures. So this study they looked at, the question was, is a 9-month high-intensity resistant training program feasible or possible, safe, and effective for women in the midst of their menopause transition, so perimenopause? And they surveyed some women and found that all these women were very concerned about their bone health and very interested in any kind of action they could do to be proactive, okay? We know that we're going to lose about 10% of our bone mass during menopause in the decade after. So the question is, can we reduce that 10% or make it 0 or maybe even add 1%? That's what these original studies were looking at.
What did they Google to find the name of it?
Lift More. It's a series of papers out of a group in Australia. This is all based on a fundamental law in nature we call Wolff's Law, named after this guy, Wolff, okay? Basically, it's the principle of mechanotransduction. So if you load bone, there are mechanical receptors in your bone that sense that load, and they will stimulate the osteoblasts to turn on, the osteoclasts to decrease their activity, and to build bone. Why? Because the body's going to say, wow, I have load here. I'm probably going to have it again in the future. I don't want to break. So let me build this area of bone and make it stronger. Same thing happens with muscle. Same thing happens with the skin. Same thing happens with every single tissue in your body, okay? I've probably talked about this before. If you've watched my other talks, when the astronauts go in space, they are known to lose a tremendous amount of bone mass because they no longer have gravity. The body senses that, says, I don't need these bones to be strong anymore, and starts to just pull the calcium out. That's why they work out so much in space and they're forced to lift weights and load themselves as much as possible so that when they get back on a 1G planet, they don't just collapse and crack in half. So Wolff's Law is a real thing. We know it's real. For some reason, in the medical literature for decades, nobody believed it and thought, oh, if a woman lifts weights, she might break. Really terrible. Bone is plastic. It can change. Bone can change. Bone senses load and torsion and tension. Bone responds to load, torsion, and tension and grows. And the opposite is true too. The old axiom, use it or lose it, is true in all things healthy and particularly in bone. So the Lift More protocol is based on Wolff's Law. And it took this one female physiotherapist to say, you know what? Why do we think bone can't respond to weight? And she actually studied it and proved that it can. Okay, another terrible slide. I apologize. We're just going to go into them. This is a different story. It followed the Lift More. This is the Stop 'em study. And one thing I'll tell you, just like all of the bills Congress puts out, they try to name studies so that the acronym is its own word. It's so annoying, but it's what they do. So this is the Stop 'em trial, strength training for osteoporosis prevention during early menopause, okay? So they looked at the high intensity program over a 9-month interval. The original Lift More work was just 8 weeks. In just 8 weeks, they improved bone mineral density. So this was a 9-month supervised high intensity resistance training for peri and early postmenopausal women. So 66% out of their pool of candidates were recruited. That's a pretty high rate. 85% adhered to the program during the program, also a high rate for a study. 90% kept it up afterwards, very high rate. What does that tell you? Women like being strong. You like feeling powerful and being able to do whatever the heck you want to do by yourself. So the only way to do that is to get strength, which means you have to build muscle, which means you have to have progressive overload, which means you have to lift weights, okay? One of the study participants, quote, says, life-changing. I don't want it to stop. So there was enjoyment, there was satisfaction, there was motivation, they felt safe, and they got confidence with this, more and more confidence. Better yet, they're preventing a future fracture. So here's the Lift More trial. This is what proved that high-intensity resistance training reverses bone loss, okay? The first to show that a very brief, only an 8-week interval, supervised HURT program was both efficacious, meaning it worked, and safe. It did not cause fractures for improving bone density, stature. So people actually got taller, believe it or not. Now, did they really get taller? No, but their posture improved. So they measured their height pre-study and after, and just in 8 weeks, people stood taller, they had more confidence, they had better balance, they walked better, there was more power in general. Everybody got empowered. So they also had better functional performance. So they looked at certain functional tests we do in physical therapy and orthopedics to see if somebody is fragile or not. They found that even the people that began this interval late, okay, improved their outcomes comparable to the people that started the intervention early. There was a group that stopped exercising and they had a deterioration in function and balance. They found that the group that started and continued reaped the most benefit, okay? And they proved that there were no exercise-related injuries over 3 years in this group, okay? So everything that was told by doctors to patients before was proven wrong. The women could lift weights. They didn't break in half when they did it. There were no injuries reported. And they felt better and improved their bone mass very quickly, actually. And then the ones that kept at it continued to reap the benefits. The people that stopped, guess what? Their bone mass went back to where it was. Just like anything else. If you stop your blood pressure meds, your blood pressure is going to go up. If you stop your anti-arrhythmia drug, your arrhythmia is going to come back. If you stop your Ozempic, a lot of people gain weight back. So even with lifestyle changes, a lot of times you still require the treatment lifetime. A lot of people criticize these lifting studies saying, well, the benefit didn't last. But to me, that's sort of such a self-defeating statement to make. First of all, we should all be exercising our whole lives. There's so many benefits. It's really the only thing that treats everything really well. Exercise, especially building muscle, treats everything from dementia to heart disease to bad skin, okay? So this first study out of Australia with an 8-week interval in the original work disproved everything and showed that we do have the power to grow bone back on our own. And then when you add these amazing drugs back in, then you're really batting 1,000. Okay. So lessons from the 3-year follow-up study. Remember the original study was short-term. Then they followed the people that kept at it for 3 years. So they continued to improve their bone mineral density. The graph went up and to the right. They continued to improve their function, their balance, their stature, their posture, their confidence, their strength. The people that stopped it, they kept some gains from the baseline, but lost most of it. The people that never did anything had the worst findings overall. So even if you don't stick with it, even doing it for a short time frame is going to benefit you. Maybe you're one of these people that only does things in January with a New Year's resolution. Maybe do a program 8 weeks every January. You're still doing better than doing nothing. But if you really want to have optimal bone health, you will do this and you will stick with it. And remember, it's only a couple days a week for like 20 minutes. This is not a big ask. So it's possible, it's safe, and it's fun, and it's enjoyable for people. Remember, there was a 90% retention rate. So people wanted to keep doing this no matter what. All right, so is it feasible if you face time constraints from employment and caregiving? So most women out there and some men have to work and take care of their family. How do you fit this in? Well, this proved that it was feasible and possible because it's such a short time to do it because it's high intensity. So you're lifting heavy for a short time, so you don't have to go to the gym for 3 or 4 hours at a time. You don't have to go to an hour class. It's literally 20 to 30 minutes a couple days a week. So it's totally feasible even if you are super duper busy. All right, remember, bone density gains, this graph shows you. The far right with the largest bar chart, those are the people that started and kept up at it. The control group, they started, didn't keep up at it. The one in the middle is they did it and then stopped doing it. So sorry, the middle one is in between, continually doing it. They did it a little bit. The bottom one is they did it once and stopped. And the tiny, tiny one that actually drops below 0, if you notice that, those are the people that never did any lifting. Like they were the control group. So they weren't allowed to participate in this protocol at all. They actually lost bone mass. So probably nowadays one would think that repeating a study like this, now that we know what we know, would be unethical. Because to ask somebody to be in the control group for osteoporosis to not lift weights, knowing that they're going to get worse, probably you shouldn't do that anymore. So we're probably not going to see a study like this again. It's a chronic disease. You have to treat it for life. So if you're going to do stuff for yourself and you want to lift weights and have lifestyle changes, you can't just quit smoking for a day and then smoke 364 days and think that's going to work. It has to be a persistent thing for a chronic disease, just like any other chronic disease. The problem with osteoporosis, of course, is you don't feel it. You don't see it. So it's sometimes harder to stick with the medication or the lifestyle. So what about medication? We have a question. Go ahead.
This lady, Carrie, they can see it, but she made the mistake of joining a Facebook group that was totally against osteomeds. And since you're about to talk about it, she's so relieved to hear you talk about the meds, studies, info. Your thoughts on that are so welcome.
Okay, so somebody out there watching this joined a Facebook group that is against osteoporosis meds. And I mean, I understand why there's fear out there. I get it. There's a wave of, I hate to use the word misinformation because that denotes so many bad things in our lives nowadays. But there's a lot of people with, I guess they don't understand the drugs enough out there spouting off a bunch of intel that doesn't make any sense to me. I've prescribed these drugs. I've seen people on it. I've used these drugs. I know the risks. I've read the literature, and I'm going to tell you what I know very briefly right now. So the medications are bisphosphonates, anabolics, and that's not like, you know, you're not going to be all juiced up in the gym. So I'm not talking about roids here. Anabolics are osteoanabolics, so they build bone. Bisphosphonates are anti-resorptives. They stop your body from sucking the bone out, so they halt the osteoclasts. The anabolics upregulate the osteoblasts that build bone. At the same time, they stop the osteoclast. So bisphosphonates stop you where you are and keep the plateau going. Anabolics can help you build bone back. Selective estrogen modifier receptors, or selective estrogen receptor modifier, SERMs. Now, some people that have contraindications to estrogen can get on a SERM because these drugs use an estrogen that only gloms onto the estrogen receptors involved with bone health, okay? So they're not going to have all of the other system-wide estrogen effects. So for the people out there, like the lady earlier, whose doctor won't prescribe estrogen, for her bone health, she may want to ask him about a SERM, a selective estrogen receptor modifier, because I believe, and I haven't read this study deeply, but I'm pretty sure that it doesn't have the same side effects in general. But her physician will have to work out that with her. And then, of course, hormone therapy. So most women, perimenopause, menopause, early menopause, should be on hormone therapy to protect their bone, cardiovascular disease, etc. There are a few and very few contraindications to this. Of course, one of them we've already discussed. Another one is if you're double positive for the BRCA gene or you have very close first-degree relatives with breast cancer history. But even in those cases, the estrogen patch has been shown to be safe and not increase the risk of cancer. Once again, go talk to your GYN about this. And, you know, like with anything else in medicine, maybe get 1, 2, 3 opinions. And I'm not talking about Chatty GPT or Google Gemini, although they're awesome and they're getting better and better. You can get that opinion, but I would still go talk to physicians deep in that world, the experts, so to speak, okay? Now, I love bone. I treat bone health all the time, so I consider myself an expert as well. But even in some cases, I will call up my GYN buddies to run things by them to make sure I'm not making a mistake or making a bad decision. So these are your classes of meds, and now we're going to just briefly talk about them.
Forteo and Timlos and anabolic.
Yeah, Timlos and Forteo are parathyroid hormone receptor analogs, and they do help build bone. The best one is Avinity. Okay, so your bisphosphonates, your anti-resorptives, these stop bone resorption, meaning they stop your body from continuing to deplete the bone mass, okay? They slow it down. It doesn't stop completely, but they definitely don't add to bone formation. What do you do if you're on an anti-resorptive to add bone mass? You probably already know the answer. You lift weights. They don't restore your trabecular architecture. So the shape of how the bone is inside the bone, you know, the bone marrow, when you're like in a chicken bone or whatever, you see all that like wavy, filamentous, like it just looks like it has this tiny microscopic architecture. It does. Your bone has a certain shape inside for a reason, because it's built to bear weight and resist tensile forces and torsional forces depending on what the bone is doing. You can even see these on x-rays. You can see lines of where the bone is denser, designed to support compressive forces versus tensile forces. So these anti-resorptives or bisphosphonates are not going to restore that architecture. They will improve the overall bone strength. They will keep the problem from getting worse. They are the cheapest. They're always going to be your first tier covered by your insurance company. Now, is that the best thing for you? Maybe, maybe not. If you think that you need an anabolic first, or your doctor does, you probably have to fight your insurance company for that for a while. Why? Because the anabolics have been shown to not work as well if they're started after a bisphosphonate. So if you think you need an anabolic, or your doctor does, like if your bone mass is so bad that you think you need to build it back, you need to fight for the anabolic before you start the anti-resorptive, because they work better that way. And then after a couple of years on the anabolic, you switch to the anti-resorptives. Okay, the osteoanabolics, the Avinities, the teriparatide, abaloparatide, these activate bone formation. They improve bone strength, and they do restore the trabecular architecture. So these are great medications for building bone back. So for people that have osteoporosis or at risk of fracture or high risk of fracture, this should be the first choice in addition to the lifestyle modification and weightlifting. The osteoanabolics with weightlifting, that is your best combination to get your bone back to good health. And I know you all have questions about side effects. I will talk about those. So anti-resorptive and anti-remodeling, and this picture shows you good bone and osteoporotic bone. So you can see the difference. The right side is osteoporosis, where it's all wimpy looking, and the left side is really good bone. The anti-resorptive and anti-remodeling is estrogen agonists. That's your hormone replacement. Your SERMs, your selective estrogen receptor modifiers. Your bisphosphonates, which we just talked about, so they glom on and stop the osteoclasts from doing their thing. Your rank L inhibitors, that's your Prolia. okay? This stops a particular protein that turns on osteoclasts. Calcitonin, kind of an old school thing. It actually goes in through your nasal passage, and it's produced in the thyroid region and is also involved in bone metabolism, but nobody really prescribes that anymore. I just put it up here because maybe that's the last thing left for somebody out there that they can take. But your main heavy hitters are going to be your estrogens, your SERMs, your bisphosphonates, and your rank L inhibitors. Excuse me. Next slide. Okay. Your anabolics. Now, I love this group because it builds bone back. So you have your parathyroid hormone receptor activators, which is the ones we just talked about, the question the audience had. And then the newest one, Avidity, is a sclerostin inhibitor. So sclerostin is a protein that turns off osteoblasts, okay? And it does it through this whole pathway. But if you can modify sclerostin, you can make your osteoblasts more active, and actually they throw down more bone. And again, all of these medications have gone through years of study, phase 1, phase 2, phase 3 with the FDA, millions and millions of dollars, thousands of people, every single side effect recorded, every problem, minutia of statistical analysis of every issue with these drugs, and also whether they really do help or not, and whether they really do prevent fracture or not. Because I don't know if you remember this, but there's this whole big thing in the Alzheimer literature world where if you reduced the plaques, you would change disease, but that did not turn out to be so true. And a lot of the new drugs are trying to go through different tacks. So even if you add bone mass back, it doesn't necessarily mean you're going to prevent fractures, but these drugs do. Weightlifting does. So the sclerostin inhibitor, or Avidity, and the parathyroid hormone receptor activators are your anabolics that you want to be on if you're very low bone mass. Reclass is a bisphosphonate that is long-acting. It is a once-a-year infusion. Okay, fracture risk reduction versus placebo. So with the anabolics, vertebral fracture rate was down anywhere from 30 to 86%. Tremendous. Multiple vertebral fracture, the kyphotic little old lady, down 75 to 85%. Hip fracture rate down 50%. Non-vertebral fracture rate down 20 to 50%. And this is as early as 6 months after starting the therapy. So you're in the high-risk fracture zone, okay? Your bone strength, you drop down. You de-risk rapidly when you take these osteoanabolics. So that drop down is when we lose our bone mass in the pink part of the graph. The yellow part is when you take these anabolic drugs, just a couple of years, and suddenly your bone mass is a lot better, and your fracture risk has dropped 50 to 86%. That is a tremendously good result. Then you switch to the consolidators or the anti-resorptives. You don't stay on the anabolics for forever. You go on the anti-resorptives, and then you get reevaluated. Some doctors will put you on a holiday. Some will put you on a different class of med. It depends. There's different ways to manage this. You probably should have somebody managing your bone health that understands this and was willing to do the repeated DEXA scans that are required. Some people will actually check serum markers of bone health. You can see in urine and blood different breakdown products of bone. That's really more prevalent in the research industry, but in some of these, when you're trying to decide, do I switch from this drug to this drug, sometimes doing a bone panel is very, very helpful. But you should probably be at least repeating the DEXA scan and probably on the same machine, by the way. Okay, so these drugs work.
Jesse Ann wants to know, will the doctor recommend medication if you have osteopenia to stop the bone loss?
So great question. Somebody just asked, Jesse Ann just asked, if you only have osteopenia, will a doctor recommend the medications? The short answer is probably not. But the long answer is they probably should. And I'll tell you why. There was just a recent study, I think it was New England Journal of Medicine, and I should have put it into this talk and I just didn't have time. A recent study that showed that osteopenic women in their 50s that got a single dose of zoledronate or the injection later on had a much lower fracture rate. So treating osteopenia a little bit seems to help a lot. Now, normally the recommendation is just take calcium and D3. which, by the way, all of these drug studies, everybody was still taking calcium D3. Now, you guys all know I have a line of supplements and natural medicine because I'm a huge believer. My very first product had calcium and D3, zinc, magnesium, C. Why? Because I wanted my people to heal well after surgery, particularly after orthopedic surgery. So you have to upregulate the immune system and you have to give your bones what they need. So I've been treating people with calcium and D3, since not med school because you can't practice then, but since residency. 1,200 milligrams of calcium a day, if you're wondering, anywhere from 3,000 to 5,000 international units of D3, in my opinion, a day. The RDAs are different. They're going to be much lower. For me, for treating osteopenia, to have optimal bone health, to reduce the risk of fragility, to reduce sarcopenia, to be powerful and healthy in your later life, 1,200 calcium, 3,000 to 5,000 units of D3 daily. And you should add in magnesium, you should add in K2, and you should add in vitamin C because you can't build the cross-links of the bone collagen without vitamin C. Anyway, so this shows you, the studies show you these drugs work. They work very, very well. What are the side effects? Everybody's so scared to death of the side effects. Probably the Facebook group, this is all they worry about. Jaw necrosis. Everybody's freaked out about the risk of jaw necrosis on these drugs. The actual risk is 0.15% to less than 0.001% person years of exposure. That is such a tiny risk of this problem happening versus the risk of 30 to 60% crappy bone and 1 in 3 people having an osteoporotic fracture and a 50% death rate if you do have a hip fracture. They just had a large UK study, England. The absolute risk is this, 0.09 per 1,000 people that never use the drug, 0.69 per 1,000 people that did use the drug. So there is a risk of jaw necrosis with this, but it's teensy, teensy tiny. And you can pick it up and you can treat it and you can stop the meds. And a lot of times it's reversible, okay? If you get a hip fracture, you might die. You'll certainly be fragile. You're going to lose a bunch of bone mass. You're going to be debilitated. So to me, the risk benefit of taking these meds, assuming you've been screened for problems, you don't have any weird random blood values that nobody's picked up. I mean, assuming you have a doctor that checks you out before they prescribe you this, the risk of jaw necrosis is so minuscule and so much easier handle than the risks of bad bone. So like I said, there's a risk of dementia now we know, and that's being studied. The risk of fracture, the risk of weakness, the risk of pain. Nobody talks about how weak bone is painful. You get tiny microscopic fractures with just random little things like stepping off a curb wrong, and your knee hurts for 4 months. Nobody talks about that. So if you don't want all of those side effects, you would take the risk, this teensy tiny risk of necrosis of the jaw, which again, you could pick up early and mitigate. So I think that's why a lot of people freak out about these meds and are so anti them. Look, I'm no big fan of huge, big pharma, but I will tell you their process is very good in terms of reporting side effects, monitoring the drugs once they're released. A full 5% of drugs that are FDA approved are pulled every year. Why? Because they actually monitor for this. And if they find something bad, they pull the drug. People are notified, people are treated, it's managed. There's a system in place. Could the system be better? Yes. But to just wholeheartedly throw these babies out with the bathwater, I think is a bad idea. If you have bad bone, I would highly suggest you get it treated. So go find a doctor that knows about calcium, knows about protein, knows about good nutrition, knows about weightlifting, and knows about these drugs, and knows about hormones. So this is going into the sclerostin inhibitor. It's just, this is a little bit detailed, but it goes through this WNT or Wnt signaling pathway that is the master regulator of bone formation. This is why Avinity is probably the most effective drug we have out there. It's a glycoprotein inhibitor, sclerostin inhibitor, which is produced by osteocytes. Osteocytes are the bone cells, okay? And it's a natural antagonistic or a natural break to the uncoupling that happens with menopause. So if you can block the sclerostin, you block the uncoupling that happens and you can build bone back. In other words, you're upregulating osteoblasts. So this slide's way too busy. I apologize, but there's very plausible, mechanistic, highly studied pathways that work. and all the risks and benefits are monitored over time. We know that it prevents fractures. We know it builds bone back. We know there's a very small risk of jaw necrosis, okay? But again, this is why you don't go out and get your own sclerostin inhibitor off of the internet from China that says research only and start taking it. You take it because it's been studied extensively and you have a doctor that knows what the heck they're doing when they're giving it to you. That's just a suggestion. But I don't think you should be as scared of these meds as probably your Facebook group is making you. That's more about this. We can go on. And the technical name is romosozumab. I can never say romosozumab or Evenity. I don't know why they name these biologics like that. It must be a contest. Like you know the color names in a J. Crew catalog or a Sherwin-Williams catalog? I'm pretty sure they have a focus group that sits and makes up drug names that are ridiculous. That's an aside. Next. All right, the Rolex Duo trial.
About your doctor suggestion, what would be the best doctor to monitor and treat more closely besides the primary care?
Oh my gosh, probably the best question
From Jessie.
Because there's no good answer, unfortunately. Jessie Ann just asked, what type of doctor besides a primary care would you go to manage your bone health? This is a problem in medicine. The orthos don't manage it. The GYNs half the time don't manage it. The endocrines are too busy to manage it. The primary cares don't really know enough to manage it or don't manage it. I had a patient the other day, DEXA scan, fully obvious has osteoporosis, and she's on prednisone from a functional medicine specialist for her adrenocortical insufficiency. So she's losing bone mass because of that. She has documented osteoporosis, and her primary care decided, no, I'm not going to treat it. It's just unbelievable. So the answer, Jessie Ann, is I don't know. Nobody has really grabbed this and made it their own. I'm doing it for my patients because I think it's that important. And I'm an ortho that has a deep understanding of nutrition, hormones, and other parts of health and wellness. So I'm a one-off, like a different person, but there are more me's. I'm not the only one. You just need to find somebody that gets it and understands all this. I don't know how to tell you to do that. But nobody has grabbed onto osteoporosis and made it their sole venue, if you will. The only thing I've noticed is infusion centers are taking over this area because it's profitable. So Avinity is profitable, Reclass is profitable. So the infusions are making hospitals money. So a lot of the hospitals are starting osteoporosis clinics. Can I tell you what those doctors are like? I have no idea. All I know is you have to go to the hospital and your insurance pays for the infusion there, and they get a sweetheart deal when they buy it wholesale and they make money on it. But you know what? If one of your doctors doesn't know everything, go see the other ones, and then you're going to have to piece it all together. All right, let me tell you about the Rolex Duo trial. Can the high intensity resistance training enhance the therapeutic effects of the drugs? So somebody studied this because it seems like a no-brainer, but sometimes the no-brainers have to be studied and proven. 8-month randomized controlled trial with humans, not just rats in Croatia. 8-month randomized controlled trial to assess the efficacy of romosozumab, otherwise known as Evenity, in combination with different exercise regimens. So this is a great study. The eligible patients were postmenopausal women with osteoporosis or osteopenia, documented, proven by a DEXA scan. Treatment arm A, Evenity plus supervised lifting. B, Evenity, unsupervised low-intensity exercise, what most doctors will tell you to do. Treatment arm C, placebo drug, unsupervised low-intensity exercise. The outcomes that they looked at. What % change in lumbar spine bone mineral density was there? And what is the change in the 5 times sit to stand test? So how quickly could people get up, walk 10 feet, come back, sit up, do that 5 times? That's one of the functional tests. So this is the Rolex Duo trial.
Dad wishes she could find an ortho with your release near South Houston.
I do too, Deb. I actually have a Texas medical license, so you could probably do a telehealth with me. Evenity and exercise. So this study, your eligible patients, your 3 groups of people, the key outcomes were looked at. This is a woman doing a deadlift. Now, some of you out there might look at that and say, wow, I can't do that. There's no way. Remember, you're going to start with just the bar, and you're going to progressively build muscle and bone mass until you will be doing that, even if you're 80. I promise. Okay, so that trial is ongoing. Some of the preliminary data has come out, and in fact, lo and behold, taking a bone building drug that's safe and lifting weights in a safe way does in fact enhance or synergize and works better together. Next time I give this talk, I'm sure there'll be more data, more studies, and the final outcomes of that study. So your action plan. So assess yourself. Do you think you're shorter than you were 10 years ago? Are you weaker? Do you feel pain in your joints? Do you smoke? Have you ate a crappy diet your whole life? Et cetera, et cetera. Go talk to your physician and see if you can get a DEXA scan, even if you're under 65, okay? Especially if you've had a fragility fracture. What's a fragility fracture? The foot fracture from normal use we talked about, or even from light running. Some people that get foot fractures from running marathons, that's a stress fracture. That's a little bit different than a fragility fracture. Breaking your leg when your parachute doesn't open is not a fragility fracture. Breaking your proximal humerus from a standing height is a fragility fracture. Many doctors see this, don't call it a fragility fracture, and don't order a DEXA scan. A wrist fracture falling from height. A lumbar compression fracture for no apparent reason. All of these are fragility fractures. Hip fractures, obvious one. If you have a fragility fracture and you're under 65, you deserve a DEXA scan. If you're diagnosed with osteopenia, treat it. Now, personally, if you're my patient, you're 50, you're diagnosed with osteopenia, I would probably try to get reclass covered, at least one injection, because of that new data coming out, that it does help long-term. Why wait till you have osteoporosis, I say? And it's been proven safe. If you have osteoporosis, I think if you were related to me or me, I would say definitely treat. Treat with whatever med works for you that you're indicated for, that there's no contraindication. Fight your insurance company for the best drug for you, okay? Don't just use their tier 1 because that's the cheapest one that they want you to take. Make sure it's appropriate for you. If you need an anabolic, get on an anabolic. Do the FRAX score, F-R-A-X. You can go online right now and do your own FRAX calculator, but you do need to know your bone mineral density scores. That'll give you your 10-year risk of an osteoporotic fracture. It's a validated study developed in Europe, country specific. So there's one for the USA, there's one for Australia, there's one for Mexico, there's one for Uganda, whatever, because each different area has a different culture, different eating pattern, different activity level, et cetera. So every population's fracture risk is a little bit different. Get a FRAX score, get a DEXA scan, just, know yourself. And then if you have osteopenia, treat it. If you have osteoporosis, treat it. First thing everybody should be doing is calcium and D3 no matter what. Probably throw in some magnesium and some K2.
Can good quality vibration plates replace the HIRT?
Great question. Somebody just asked if good quality vibration plates can replace lifting. I don't think it can replace it, but you certainly could do that. I'm probably going to get one just for general bone health going into my future. They have been shown to help. So it has to be a good quality one. And the whole theory is that the shaking and the impact on the bone stimulates the bone formation. So if you have that or you can get one, I would get one. Can it replace lifting? I don't think so. I think you should get out there and find someone and start a lifting program. But again, has anybody studied that? No. So this is just me talking. Okay, here's the people that should probably get checked. These are some guidelines that have been put out. Prolonged use of glucocorticoids, not just oral prednisone and things like that, like if you have autoimmune, but all the people out there who are getting dexamethasone from doctors that think they're deficient in cortisol. All the people that are getting repeated series of spine pain injections. There are a variety of ways that we get steroid into our body. If you have more than 7.5 milligrams of prednisone a day for 3 months or the equivalent, you are at risk of osteoporosis. History of minimal trauma fracture, fragility fractures. Height loss or back pain suggestive of a vertebral compression fracture. If you're older than 70 or 65, by default, you should get one. History of falls. This means you have poor balance and you're at risk of future falls, which means you're at risk of future fractures. Parental history of a hip fracture. If your mom or dad had a hip fracture, you need to get screened stat. Low body weight, low muscle mass and strength. We already talked about how the super skinny tend to not have built up that skeletal bank account. They don't have the investments in place for the retirement. Low physical activity or prolonged immobility. So what is prolonged immobility? You were in the hospital for 3 weeks. You had COVID and you were laid up for a while. You were in the unit for something. You had a heart attack and you didn't do anything active for a while after that. Whatever your prolonged immobility was, you're probably at risk and should probably go get a DEXA scan. And then what do? So in your youth, we already talked about it. Get the calcium, get the D3, get out in sunlight and exercise. Check. Adulthood, make sure that you're not taking any of those drugs that diminish your bone mass, like corticosteroids. If you have to be on them, get screened to get treated. Understand high fertility patterns. Like if you've had 8 or 9 kids, you may want to get your bone mass checked. Okay. If you know for a fact you've had a crappy lifestyle, smoked, ate ultra processed foods, probably go get checked. If you've let yourself go to pot and you're very weak and you've not lifted a weight ever, maybe go get checked. Menopause and beyond, consider hormone replacement therapy if it's at all possible. Even people with the risk factors can have estrogen patches in most cases, okay? Go talk to your GYN, your primary care, or an ortho like me that understands the hormone treatments. Get into a supervised high-intensity lifting program, Lift More protocol, okay? Or at least something similar to it. And there are specific exercises with specific weights, 70% of your 1 rep max, 3 to 5 lifts for 3 to 5 reps. So it's a protocol, okay? Don't just go to the gym and try to start to lift some weights at Planet Fitness after the free pizza yourself. That's not my suggestion. Go talk to a physical therapist about this or an ortho like me that understands it. And then lastly, strongly consider the medications if you have osteoporosis or even if you're osteopenic and bordering it, like you're -2 or you're -2.1. I would strongly consider at least 1 dose of a bisphosphonate in that category. And then if you're osteoporotic, I would say anabolic, then the rank L inhibitor, and then the bisphosphonates to hold you. So a series of medications over years, plus the lifting. So you can manage this. You can get taller, you can get stronger, you can be healthier, you can have better bone mass, you can have better muscle mass, helps your brain health, helps your heart health, prevents fractures. Fractures can kill you, hip fractures, certain lumbar fractures, etc. They can change your posture, they can change your balance, they can make you fragile and weak. So if you miss the boat on building your peak bone mass, all is not lost. I just gave you all of the tools you can use. Basically, fight back. Know it's a chronic disease, and yes, nothing works once and that's it in most cases, okay? You don't get 1 dose unless it's genetic therapy, and they have not come out with that yet for this. So you're gonna have to treat a lifetime if you have this problem, just like I am gonna be wearing glasses my entire life. Been wearing them since I was in college, it's not gonna stop, okay? Same thing with most chronic problems that people have. You just have to keep treating it. If you're autoimmune, you keep taking your autoimmune meds. If you have heart disease, you take your drugs. If you have high cholesterol, you take your statins. You may or may not have to take CoQ10. You probably should take it to prevent the muscle problems, et cetera, et cetera. Invest early in your bone health. Eat enough protein, especially as an adult, 30 grams per meal. Okay, 6 eggs per meal is effectively the amount of protein you're supposed to be eating. Protein is the what collagen is made of. Bone is type 1 collagen. Without protein, you don't have bone. Adequate nutrition, adequate calcium, adequate D3, adequate other minerals that help do the mineral phase, so like phosphorus, magnesium, etc. Invest early, build this up when you're a child or adolescent. If you didn't do that, at least get on it now. Monitor the withdrawals out of your bone bank account, reproduction or babies, menopause, early menopause. If you've had major withdrawals from your bone bank account at any given point, even a fracture, anytime you're healing a fracture, your body's going to pull calcium out to heal it. So just monitor the withdrawals, know that they've happened, go get checked, get treated. And then reinvest. How do you reinvest? high intensity resistant training, the medications, change your diet, the appropriate supplements, calcium, D3, magnesium, zinc, C, lifestyle. So don't smoke, don't excessively drink, don't not sleep, don't not exercise. So it's the basic stuff we've been telling you all along, the meds protocol. Mindset, exercise, diet, sleep, get that right. And then if you actually have a true problem picked up by a DEXA scan, go find a doctor that knows how to treat it. I wrote a book about a lot of things that we just talked about, not specifically about osteoporosis, called Bone on Bone, but it goes into the meds protocol. But I would say consider the Lift More protocol. If you don't know how to lift weights, don't be scared. Somebody should be supervising you anyway. In the supervised thing, they make sure you know how to do it, that you're doing it properly, that you're not overloading too quickly, that the progression makes sense. Okay. So there's no reason to be scared. It was proven safe. Remember, no adverse events, no exercise-induced injuries. We know hip fractures kill. The risk of osteonecrosis is minimal with these meds. So you need a whole, all of what's best for modern medicine and the nutrition supplement side. It should not be all or none in any of our worlds. Any questions?
Carrie, she's just upset they didn't start her on Avinity. She has osteoporosis at 54. PCP probably doesn't understand.
Yeah, so Carrie, somebody that has osteoporosis at the age of 54, was not started on Avinity. And likely, I don't want to speak for your PCP, but perhaps they did not know that Avinity or one of the other anabolics. Now, that side note about teriparatide and abaloparatide, if you have hyperparathyroidism, you can't take those, okay? So again, you have to be screened and do a panel blood. So you have to have somebody that knows what they're doing. The more likely scenario is that it wasn't covered or wouldn't have been covered, and they just figured they didn't want to, like, it didn't even enter their head to fight the insurance company for it. It may not be too late. You can do an anabolic. It's just not going to be as effective as it would have been had you started that before the bisphosphonate, but you still will build bone back.
Any suggestions to get more protein outside of food?
Any suggestions on how to get more protein outside of food? No. The best way to get protein is through food. Anything you take is getting broken down into the constituent amino acids anyway. Your body was set up to extract nutrients from food. So I get my protein from food, animal protein, plant protein. Plant protein's highly inefficient. I would like literally have to eat all the time, all day to get enough protein out of plant protein. So I still eat meat. I just make sure it's high quality meat with, organic, grass-fed, grass-finished, whatever. Food is the best way. Short of that, a lot of people are taking collagen. That's still technically food. You're eating it. Protein shakes, same thing. It's still food. The best way to get protein is through the mouth, the alimentary canal, the stomach, and the intestines. That is the best way to get protein. I'm not a fan of protein shakes because it's pretty much ultra processed in a way. Like, how are they getting this protein? They're extracting it from substances in a factory, lyophilizing it, powdering it up, and then packaging it with preservatives and emulsifiers and whatever so it doesn't cake. So I'm a big fan of whole foods, natural foods, the Mediterranean diet. So I try to get my protein from food. Plenty of people take protein shakes. They'll swear by it. I know there's a gazillion products on the market. Same thing with collagen supplements and bone broth. I make chicken stock from scratch, the old school way. That's the best way to get your bone broth. If you've ever seen pho made from scratch from the chopped up oxtail, again, a great way to get collagen in your diet and protein. But I think food is probably the best way. But that's just me.
Why don't you tease them about what's going on next weekend?
Oh, right. So normally I do this once a month with an exception for the holiday months. So normally my talk would be next month, but I'm felt obligated to give this next talk next week because I'm getting super aggravated at what's going on around me in the medical community. I'm going to talk about peptides. You've probably heard about them. You're probably wondering if you should be on them. I'm sure every millennial and Gen Z around you is on them or taking them. Your doctors are peddling them. You can buy them online from China. What are they? What are they all about? Why are people taking these? What are the risks, etc.? So I put together a talk with all of that. I'm gonna give it next week because so many people keep asking me about them and want me to give them peptides, but it is illegal, flat out, full stop, for a physician to prescribe, recommend, sell, et cetera, peptides right now in this country, with the exception of the studied ones that the FDA has approved, like semaglutide and Mounjaro. Otherwise, I'm not doing it because I don't want to lose my license and I don't want to break the law. I'm going to talk about them though, because you can go online and get it yourself right now and do it yourself. And a lot of people are doing that. Why is beyond me, but they are. I'm going to talk about everything I know next week. So hopefully you can watch this next week, Saturday. All right, take care. Go enjoy your weekends.
Jesse said, thank you so much for what you do.
Oh, you're welcome, Jessie Ann. And then go out and find somebody that can get you on one of these protocols. Even if you don't have osteoporosis, you'll feel a ton better.